This is the summary of anti-anginal drugs. There are only 4 classes of drugs, 1 drug each. I want you to remember, very super important. Nitrates, dihydropyridine calcium channel blockers, beta blockers, and late inward sodium current blockers. Okay. First 2 classes of drugs are targeting the blood vessels, nitrates and dihydropyridine calcium channel blockers. Nitrates are targeting the veins mainly. Of course, both the arteries and veins can be dilated by the nitric oxide produced from nitrates. But keep in mind, veins are very flexible. Therefore, veins are the one mainly acted by the major effect of nitrates. All the drugs in the nitrate class is targeting on veins. But dihydropyridine calcium channel blockers are targeting mainly on the arteries. Okay, so nitrates reduce the preload of the heart. Dihydropyridine calcium channel reduce the afterload of the heart. Then the next 2 classes directly targeting heart. That means by targeting the contractility of the heart, beta-1 blocker specifically reduce the heart rate also. Okay, so let's talk about that. First one, nitrates. Major points to remember, how it works. Target is veins, then it releases nitric oxide. Then the second class, dihydropyridine calcium channel blockers. Why it is specific? Calcium channel blockers are 2 types. Because of the unique structure, some drugs can only get into the cardiac muscle and affect the cardiac muscles calcium channels. But because of its unique structure, in dihydropyridine calcium channel blockers, they can easily access the vascular smooth muscles, and this can block the specific channels. L-type voltage gated calcium channels can be blocked. Why it is super important that L-type and voltage gated calcium channels? Because our body has so many calcium channels in every cells. If you are generally blocking the calcium channel, your body will shut down. That's not what you want. That we need to specifically target the L-type voltage gated calcium channel so that all our other body system will work. Only the angina causing causative reason will be blocked. Okay, so another point to remember, nitrates are mainly for symptom control. Anginal, that is chest pain, can be controlled by nitrates. Then calcium channel blockers can be first line for vasospasm. For instance, coronary vasospasm can cause variant angina or Prinzmetal angina. How I remember is, Prinzmetal was a doctor in 1950s who found out what it is, that variant angina. I remember Prinzmetal is a variant, different name. So that's how I connect that. So the variant or Prinzmetal angina is due to the coronary artery vasospasm. Therefore, I am going to use a drug which directly targeting the arteries, coronary arteries and coronary blood vessels. So if I can dilate the coronary, if I block the L-type calcium channels in the coronary arteries, I don't get that spasm. So I can specifically dilate that coronary, keep dilated. Coronary artery will be dilated. That is the reason amlodipine or the dihydropyridine calcium channels like a extended release nifedipine can be effective for treating that condition. Keep in mind that specific indication. But when you look at the beta blockers, because it is targeting the heart's specific beta-1 receptors, we can use it for stable and unstable angina, act as a first line therapy. Reason, especially if you look at the unstable angina, you have to use that drug because unstable is because of that clot formation. So you need to make sure the cardiac muscles get less myocardial oxygen demand. That is super important. That is the reason beta blockers can be very effective for unstable angina and also for stable angina. In stable angina, remember the term is fixed obstruction due to the atherosclerosis, right? So therefore, if a patient do some exercise and walk around, so in that time the heart needed a lot of oxygen, but the coronary arteries cannot dilate and provide more blood to that heart. That is the reason when you use metoprolol, succinate, or the drugs specific to beta 1 receptor blocker, we can reduce the heart rate and cardiac muscles activity. Therefore, heart's myocardial oxygen demand is reduced. That is why for stable angina is also we can use this as a primary drug. Okay, so if you talk about major 3 types of angina, one of the types, variant or coronary vasospasm angina, the go-to drug is dihydropyridine calcium channel blockers. Because if you give beta blockers, it will not be effective. Reason beta blockers working on your heart muscles and a pacemaker, right? Heart. So you need some drug which directly helping the coronary artery. That is the reason that specific indication is amlodipine, the major go-to drug, or nifedipine, because nifedipine has little more adverse effects. So and also not the short-acting one, nifedipine, that is not the one to use. Amlodipine is a well-tolerated. We're going to discuss in little more in details. Then beta blockers I was talking about. In addition to this, nitrates for always the quick-acting nitrates for symptom control. You need to reduce the chest pain, so we can use that nitrates for all the types. But for the stable and unstable, I want you to remember as go-to drug is beta blockers, okay, for prolonged control, okay. So last one for chronic angina I am going to talk about, because it can be very effective for ischemic heart muscles. It has very unique mechanism. Okay, so if you look at generally, nitrates have mechanism by releasing nitric oxide so that you dilate the blood vessel, but specifically veins. Dihydropyridine calcium channel blockers specifically targeting the L-type voltage-gated calcium channels so that it can dilate all that blood vessels, specifically because it is arteries have more calcium channels aggregated, L-type, therefore arterial smooth muscle dilation, very good. And beta blockers will be targeting the by blocking the beta 1 receptors of the heart. Keep in mind, in heart there are 3 places I want you to remember: in the SA node, AV node, and all through the cardiac muscles. Specifically remember, ventricular myocardial cells have a lot of aggregates of beta 1 receptors, so that sympathetic it can be regulated by sympathetic nervous system. But when you use beta blockers, this will quickly blocking or slowing down the target SA node, so that your heart rate will be going down, and the AV node slowing down the conduction into the Purkinje fibers and a bundle of His into the ventricle, and the main topic to relax the heart, the contractile tissue of the heart will be reduced. Okay, so the function will be reduced. Okay, so another point, nitrates generally you have the contraindication in other nitric oxide releasing drugs, specifically like a Viagra, right? So that drug is actually sildenafil. That's a phosphodiesterase 5 inhibitor. If a patient take Viagra, they actually in males, of course, they work by releasing nitric oxide so that penile tissues blood supply will be like the blood vessels will be dilated. So that's a mechanism of action. If you are adding nitrates to that patient within 24 hours, in that 24 hours a lot of blood will have that drug content, and the nitric oxide will be higher in that patient's body. Therefore it is absolute contraindication to add nitrates in that patient. Okay, keep in mind, if you are asking about what is the contraindication or what is the major no or to the calcium channel blockers, if a patient has severe hypotension or taking any drug which causes severe hypotension, you should stay away from dihydropyridine calcium channel blockers. What is the reason? Easy to remember. Dihydropyridine calcium channel blockers are specifically dilating all the arteries so that the hypotension can be an adverse effect, right? Therefore, avoid the drugs which causing severe hypotension. If you are asking beta blockers, what is the go-to? Like if you are talking about one drugs should be avoided. Reason: beta blockers will be slowing down the heart rate, right? Therefore, if a patient has severe bradycardia, or if a patient is taking any drug which causes severe bradycardia, you should avoid beta blockers. Okay, and ranolazine, the last drug, late sodium inward current blockers, these drugs, they can slow down the heart contraction. I'm going to talk about this can reduce the calcium overload in your heart. This is like ranolazine help to relax the heart. So that is the reason. Reduce the sodium channel. That's how indirect mechanism. They can in turn reduce the calcium overload also in the muscle. Therefore, this can cause indirect effect on the potassium channels and results in QT prolongation. That's a big one. QT prolongation can be a risk in patients. Therefore, if a patient taking another QT prolongation causing drug, you should avoid ranolazine. Okay, let's look at the drugs one by one. Nitrates. What is the major things to remember? First drug, nitroglycerine. You can have quick acting, very like a immediate relief drug. That will be the sublingual, or you can have spray. So this one, if a patient has a really severe chest pain, you need to work really quick. That means it is a immediate release, like a very short acting, and work really fast. That means very simple to understand. Once you put it under the tongue or to give as a spray, it can easily diffuse into your blood, and it can easily pass through your endothelial cells and reach up to the smooth muscle. Okay, but what is the unique mechanism? Why it is effective in all type of angina? Unique mechanism is both these endothelial and smooth muscle cells can produce nitric acid from nitroglycerin or all the other nitrates. Therefore, it can be releasing and relaxing the blood vessel. Very good. Specifically, nitrates, the veins are very stretchable, right? Very compared to arteries, veins are very stretchable. It can pull a lot of blood. That is the reason this drug can stretch a lot. Venous dilation is high in nitroglycerin. What is the other major things to remember if you are talking about nitroglycerin? Remember, transdermal patches are available, and if you take oral drugs to for the prolonged control of the or long-term prevention of angina, always remember the drug has to be, you need to wean the drug at night time, because this drug can become tolerant. Okay, tolerance has to be prevented. That is the reason. Specifically, if it is a daily patches at night, patients has to be removed. Okay, another major adverse effect of nitrate, generally it is throbbing headache. Okay, two adverse effect, if you have to remember, two adverse effect of nitroglycerides are throbbing headache, or a migraine headache, or throbbing headache. That's a major point. And also orthostatic hypotension. Both are related to veins You can easily remember orthostatic hypotension because of that inferior vena cava's blood. As soon as it dilate, blood circulation, enough blood is not getting into the brain. You understand that. Keep in mind that's another one. The second one, directly affecting your brain. So why patients get throbbing headache in the brains? You have your dura mater, right? Dura mater has a lot of nociceptors, and also the meningeal artery has a lot of nociceptors. As soon as the meningeal blood vessels dilate, veins, including veins, when it dilates, both the dura mater nociceptors and the meningeal blood vessels nociceptors going to be activated. That is why patients get throbbing headache because of nitrates. One more point I wanted to add. If a patient has really bad migraine headache, nitrates are contraindicated. I want you to remember that point. Okay, so then isosorbide dinitrate. There are two types. They are dinitrates and mononitrate. Dinitrate is a longer half-life drug. Isosorbide dinitrate is the one mainly using for long-term prevention of angina, and isosorbide dinitrate we will learn in the heart failure lecture. Specifically, these drugs are dilating the vein. Therefore, this drug can be combined with another arterial dilating drug called Ranolazine that can be useful for heart failure patients. So keep in mind, isosorbide dinitrate, we will see that drug in the next lecture. Okay, next summary. So, okay. That's the reason I just highlighted nitroglycerin first. If you can study that one drug, you will understand everything about that class. Second class, dihydropyridine calcium channel blockers. Okay, so we already discussed nitrates. Contraindication is phosphodiesterase 5 inhibitors, PDE inhibitors called sildenafil. That's a Viagra. Okay, because both the drugs release nitric oxide. That is the mechanism. Okay, you understood how throbbing headache, that is a direct dilation in the brain, but dilation in your inferior vena cava causes orthostatic hypotension. Okay, we are done with that. Then the next one, calcium channel blocker, I already explained to you, but if you have to remember mechanism of action is specific to blood vessels, dilating the arterial system, arteries a lot, right? Specifically artery. Reason, specifically L-type calcium channels, voltage gated calcium channel is aggregated in those tissues. Therefore, vasodilation will be there, afterload will be reduced, the chest pain will be reduced, and also unique to that coronary heart's coronary arterial blood supply can be blood vessel can be dilated. Therefore, specifically vasospasm or variant angina or prinzmetal angina, you can be cured by or controlled by this amlodipine. That's the first go-to drug. Reason, there is old drug. First generation drug is Nifedipine. That was a short-acting drug, but it can get like a various adverse effect. Therefore, we have Nifedipine extended release drug. But one problem with the Nifedipine is you can get a flushing, headache, edema, all those. Therefore, we can use a third generation drug, that is Amlodipine. If you are thinking about second generation drug, we already learned in hypertension. If a patient has hypertensive emergency, specifically with a hypertension encephalopathy, you can use Nicardipine. Nicardipine is a second generation dihydropyridine calcium channel. How I distinguish these three drugs are Nicardipine, CAR. If somebody have a hypertension emergency, we don't walk to the hospital. We will take car to the hospital. That's how I remember. Then that is an entirely different drug. I want you to remember that is an IV drug, right? It's just like a quick action. Okay, so that's an entirely different drug for hypertensive emergency. But keep in mind, first generation Nifedipine extended release, you can use it for anti-anginal, but the better drug is amlodipine. So specifically, if somebody has to give a variant angina or coronary vasospasm, you will pick the drug which is dilating your coronary artery. That will be amlodipine. Very good. So in amlodipine, what are the major things to remember? One additional point, mechanism of action important, indication important, and what is the class, that's important, class name. And the last point, peripheral edema is the one unique, of course it is specifically vasodilation or hypertension can be an adverse effect, but this has a unique peripheral edema also can be possible in patients. Okay, so keep in mind, and maybe massages and all those other points can help with this patients. Anyway, we don't want to get into those. We are sticking with the pharmacology here. Beta blockers. Let's look at beta blockers. Why it is good for stable and unstable angina? We already discussed that. Okay, so let's look at it. Whenever I mention, everybody talk about beta blockers. I want you to remember as beta 1 blockers for anti-anginals. What is the reason? I'm going to distinguish with the other non-specific beta blockers called propranolol, not for cardio-specific. Reason, that drug pass blood-brain barrier and that has more effect on other receptors, and therefore we are not going to look for cardio-specific mechanism or symptom control. Okay, so beta blockers, beta 1 blockers. What do you have to remember? Specifically metoprolol, succinate. There are two types, and succinate form is the one good for anti-anginal and heart failure and different. We will talk about it. So let's talk about that. What is the one thing you should never forget? That's the point. Beta 1 receptors are a lot aggregating. We already discussed SA node, AV node, and throughout the cardiac muscle, specifically your ventricular myocardium. Therefore, why is it there? Because sympathetic nervous system has to be stimulated, right? And norepinephrine, epinephrine, whenever necessary, you have to increase. If you have to run from, run from a bear or a lion or a snake or something, what do you have? You have to increase the blood supply to your muscle and your brain so that you can think where to run and escape, right? Therefore, your sympathetic nervous system will act really quick. That is the reason these beta 1 receptors are targeting those areas. Okay, so keep in mind, heart rich in beta 1 receptors. Specifically, I wanted to remember these three. Therefore, mechanism, adverse effect, everything can be connected in all the different drugs we are learning in future in next 2 lectures also. Okay, metoprolol succinate or beta 1 blockers. How do they do? Okay, as soon as the patient takes, it's going to block that. Block means like of course, it will come targeted to beta 1 receptor aggregator area of the heart. What is the end result? That is the point you have to remember. 2 major points. One, you already know, it reduces the heart rate. It reduces the heart's muscular contractility. Okay, so that heart rate will slow down. Beta blocker is telling the heart, calm down, slow down. So that heart beat is, that is the heart rate is lower, and it will contract on also, like it relaxed and contract, right? So that's the one point. Second one, as a result, cardiac output will be lower. So reduce cardiac so that the heart get like a lower workload, so that pain angina will be reduced. The drug we are going to talk about is metoprolol succinate. This is the mechanism. If you know the class mechanism of action, that's the same mechanism. Very good to know. And what is the additional point to remember? Maybe you can remember about the major adverse effect of bradycardia, and the go-to drug is extended release, that is 24, like a steady release drug, metoprolol succinate. Not I don't want you to remember metoprolol tartrate. Reason that has a like a not good pharmacological advantage over the succinate. That's why I wanted to, because short half-life, that the other one was like about 3 to 4 hour short half-life. So just study metoprolol succinate. I think we are taking too much time. Let's shut it down soon, okay? And the last one, okay? I think you understand. Okay, adverse effect is, I told you, bradycardia can be. Because why? Because the heart can slow down. So therefore, if a patient already taking heart failure, lower heartbeat drugs, this is not a good drug to add. The last one, this is typically indicated for latest drug, indicated for, of course, 2006, not latest, indicated for chronic angina. What is the important thing to remember for chronic angina? In this point, let me turn off the air condition. Hold on a second. Okay, sorry about that. I don't want any noise or distraction. Okay, so we were talking about a Ranolazine drug. So this is the point. In chronic angina, especially in the how do I say, like ischemic heart. Ischemic heart, some of the sodium channels cannot be deactivated. Okay, deactivated, or the sodium channel going to work continuously. Therefore, it will start accumulating a lot of calcium. This will make the heart to keep working. That means body get a signal that, oh my God, my heart is failing. Therefore, this is going to push hard. So that is the specific mechanism. Let's look at the picture, then we will come back. Okay. So this is what the story. Especially in chronic angina, why this drug is an add-on drug, or this can be very effective, because it has a unique mechanism and not a first-line agent for primary angina. Okay, keep in mind, if in the chronic stage, our hearts, some of the sodium channel, especially the late sodium current channels, there are different names there, I don't want you to confuse. Some of the invert sodium channels will be going to activate and push a lot of, that means it's like our door lock is not working, right? Similarly, our sodium channel is not working. You need to stop at some point. It will not close. It will keep open, and all the sodium will be coming in. Inward sodium current will be high in pathological condition. Look at that. See, invert sodium channel has to be very low, but it will be keep open. A lot of sodium will be pushing in. Therefore, the patient get like a severity, because it will in turn increase the calcium influx and release, and therefore cardiac muscle is contracted. Poor cardiac muscle is not relaxing. That is the point, okay, to remember. So that means if you use late sodium invert current channel blockers or inhibitors, if you can block that specific sodium channels, oh, did I say calcium? So if I can block the sodium channel, specific late sodium channels or late invert current blockers, if you are blocking that current, we can in turn reduce the secondary function, right? Secondary function, reduce the calcium, therefore asking the heart to relax. Ranolazine will make it relax. Okay. Another point to remember, this drug, because it is relaxed, it has, why it is good for ischemic or chronic heart as angina patients. Reason, it has another mechanism of action. Let me talk about that also, right? This can stop or reduce fatty acid oxidation. That means Ranolazine, it's like a partial fatty acid oxidation reduction. Ranolazine's unique structure will also help to stop the use of fatty acid in the heart, but instead it will help to use more glucose. That means easy to understand. Glucose breakdown we need some oxygen, because anginal condition, oxygen demand is the one important, right? because we need to reduce the oxygen demand. Then patient will not get that cardiac anginal pain. Of course, you already know. That's why I didn't explain. If somebody asks you what is causing you pain, reason because blood is not supplying enough oxygen to the heart muscle. Therefore, heart is tempted or forced to switch oxygenate like a oxygen dependent mechanisms to anaerobic respiration, right? Therefore, instead of oxygen they're going to deposit a lot of lactic acid. Think that way. Lactic acid, and it will stimulate like a more hydrogen ions, more bradykinin. All these will stimulate your nociceptors and give the signal. That's why chest pain. So that means ranolazine's mechanism is also an addition. How? Instead of fatty acid oxidation need more oxygen than glucose oxidation. So it will make to stick with the glucose. Ranolazine will tell the heart, okay, we don't have much oxygen, so just don't use the fatty acid, but just stick with the glucose for the time being. And also, instead of that contracted heart, it will give that relaxation. How they indirectly reduce that calcium channel, calcium aggregation, how it will be blocking the constitutively active L-type or late sodium channel current. That's how it's going to be blocking that function and make the heart to relax. And the last point to remember, because it's doing that, the adverse effect is QT prolongation, because it is very like a different mechanism, but mainly that L-type sodium channel is going to relax. So QT prolongation is one of the major adverse effect of this drug, ranolazine. And because of QT prolongation, you should never add another QT prolongation causing drugs, especially like major drugs you can remember. And for one example is levofloxacin. If you are adding that drug to a patient for pneumonia or some, especially the patients with a heart failure has a lot of major additional other diseases, they can get, or infection. Some other drugs are contraindicated. You may need to pick certain drug which is specifically QT prolongation. In that case, you should not add ranolazine. Why? Recent studies proved that, or evidence-based science, medicine or clinical studies shows that ranolazine is good because it has a very unique mechanism, and also in ischemic hearts continuously open this late sodium channels. That is, that current can be blocked by this specific drug. Therefore, in addition to the other drug, you can add this drug also. Okay, keep in mind, I think this is the major thing I want you to remember. We are done. I think I cover everything. But what is the big thing to remember? Big picture. Nitrates, you can use it in all the types of angina because that is a major symptom control. Quick action, 1 to 3 minutes if something is working, that's the one you are going to go for. Dilating veins. Then nitrates and dihydropyridine calcium channels are targeting the blood vessel. Therefore, the first two in the first two classes, we are going to targeting the dilation of the vessels. So, dihydropyridine calcium channel blocker like Amlodipine or Nifedipine extended release, those drugs will be very effective for variant angina. That is specifically because of the coronary artery vasospasm. Very good. And the last section is 2. I wanted to study two like that so that it will be easy. First 2 drugs targeting the blood vessels. Out of that, nitrates targeting the veins, dihydropyridine calcium channel targeting the arteries, beta blockers and the last one targeting the heart directly. But in the beta blockers, be it beta 1 blocker targeting your SA node and AV node and also the cardiac muscle. I forgot to mention one more point. Remember, I was talking about if you have metoprolol, atenolol and propranolol, you will pick metoprolol succinate for the anti-anginal drug. Reason, this is better like proven because of the unique structure and all the pharmacokinetics. But if somebody asks you one question about the propranolol, keep in mind propranolol is non-specific. We need a target which is targeting the SA node, AV node and the cardiac muscle. That is the beta 1 receptor 1. Okay, but propranolol has unique, like a non-specific beta 2 receptor. So you have different target there. So that means that is not a cardiac specific mechanism. Also, propranolol can pass. Of course, metoprolol can pass, but propranolol can pass. I have to look at the metoprolol, but it is actually a lipophilic drug. That's what I was mentioning. Metoprolol has a slight lipophilic nature, but propranolol easily pass through the blood-brain barrier, and it is a highly lipophilic molecule and very small enough to pass through that. Therefore, it will be effective for all the CNS symptom control. Some conditions you use it propranolol. If you are comparing atenolol will not pass blood-brain barrier because it is a hydrophilic drug. Okay, atenolol, that is the reason if you have to choose from propranolol and atenolol, that's the one drug for cardiospecific, especially if you have to avoid that non-specific symptoms in the your bronchial tissues. You can go for atenolol. Otherwise, you will go for metoprolol. Metoprolol has a specific target, beta 1 receptor. Atenolol also has a specific target for beta 1 specific, but the problem is if you compare the adverse effects and all the other pharmacokinetics, atenolol is very lower efficacy compared to metoprolol for anti-anginal and different functions. Okay, and I think I covered everything. I took too much time. I'm sorry about that, and hope this helps. Okay, I will try to add heart failure drug summary. This will be very helpful for your board practice. I wanted to review this before you go to the board exams. Okay, thank you. Bye bye.